Okay, we have our second example here, and we'll get a radiograph of it, as you can see. I guess it's upside down there.
It doesn't matter, you know what, because I'll just flip it.
Okay, all right.
You just do it it's easier for you.
Okay. And this will be a similar situation. I think this one's a little bit buccal lingo. We'll see there. It's underneath that concavity there, and we'll probably do the same thing. They expose that. We'll probably split in half, trying to take out one piece. In order to take out a one piece, you'd have to go out this way to take out a tremendous amount of distal bone there. So again, we want to preserve as much bone as possible. So just get a little buccal groove and a little distal groove in there. Play with a little bit, probably section in half, get the distal half, and then the mesial half out there. So this is what we're going to do. Very similar thing. We'll do that little buccal groove and distal groove. Again, we'll try to come down through here, and then we'll take this distal half out first, and then second we'll do this one right here. Okay, again, I'm going to do that little thing where you just kind of make a ideal, try to visualize where you think the third molar is located here. Central fossa is right about there, and again your lingual nerve in 5% of the cases is going to come down with a buccal nerve and then go right immediately distal to that and over here. So you want to stay away from that distal lingual corner of the third molar. So again, same type of flap, coming out of the distal lingual of the second, come right about over the central fossa right there, and then continue that out in the buccal vestibule there, come around here, and that one's we may or may not, well, let's see, we may do a little releasing incision, we'll see here. Sometimes I don't do the releasing incision until after I lay the flap, and if I need it, I'll do it. If I don't need the anterior releasing incision, I won't. It actually cuts pretty good. Kudos to Dr. Mark for all his work in trying to simulate the human jaw and tissue here.
That actually came from Europe.
Oh, did it? Okay.
Somebody came to our door selling chamois, and we ended up spending a little more than normal. So it's turned out well. You got a different blade there, sir?
Well, I think it's pretty good. Yeah, we'll do it right there. This one's a little lingually displaced. Again, it's a little bit covered by the flap, but if you reflect the flap, you get out all the way underneath the periosteum. That lingual nerve is in the soft tissue, it's not in the bone, so you can get all the way underneath the periosteum and reflect it gently, and you move the lingual nerve without damaging too much. Got a little tissue tag there. This is oral surgery demonstration, not a periodontal surgery, so give me a little slack, please. I need a little more reflection there. Well, I hope you're able to see this, because like I said, I've seen lots of demonstrations on film, and even looking over a doctor's shoulder, it's really almost impossible to see anything. So hopefully this demonstration will help illustrate this real clearly. Okay, again, we're going to do a little buccal groove and a little distal groove here. Again, I'm just using the crown, side of the crown, like I said, like you use a fence in a wood shop. Just guide the burr along the surface of the crown, stay close to the crown, just like you're doing a crown prep. That way you do minimal removal of bone. I use a 702. This 703 is for demonstration purposes. 702 tends to jam a little bit with the flash and stuff here. going to use my little Woodson here, kind of probe around there and feel what we got there. This one has a slight lingual inclination, you see, from the buckle. Usually they're the other way, but sometimes we get those, they can be a little tough. Sometimes on these, what I'll try is I'll just go ahead and since the crown is off that way, I may be able to deliver the crown out with a lingual without doing a whole lot of sectioning, any more bone removal. Sometimes on these, I'll use a little purchase point and try to get a Cogswell B point down in there. Now, Cogswell beads will not put a whole lot of force on a tooth. They'll break it if you do, but if you have a tooth that's not really anchored in there really well, you can get a good purchase point on it. Sometimes they'll elevate out pretty easily. We'll see here. This will probably break because it's a brittle tooth. Make sure you have a bite block on the other side when you're doing this. Okay. Well, it's wiggling, it's not loosening up, so this is a good teaching point. There's a minimum amount of torque, maximum amount of torque you want to put on these teeth, so if you're really starting to torque it a little bit there, maybe you just got to go ahead and we'll section it. But a lot of those cases like that, since they're not under occlusion, they're pretty loose in there once you can get access to it, so, try something different. We just tried something different there, it didn't quite work, but that's all right. So I'll go ahead and complete the section of the crown here. Saline gas there. Okay, I got the basic groove there, and again, I'm going to widen out the groove a little bit, so it's a little bit wedge shaped, so that elevator, so that the Cogswell A or whatever elevator you want to use in there will seat in there pretty far. I think you can see that a little better there now. See, it's a little bit wider here on the outside. It goes down there pretty deep.
Just do that one more time. Hold on. You can actually leave it right on just put it right down.
Okay, right.
And then I'll zoom right in.
Okay.
I know it's counterintuitive.
But it's pretty, oops, let's see. Yeah, I can hold that back my feet. See, it's a little wider on the outside. It goes down pretty deep. That's usually enough for a live tooth. This one may break because it is a desiccated dry tooth here. We'll see what happens here. Then section real quickly. I'm gonna do a little more cutting on it probably because it's just brittle. It's gonna break. I think we soaked them in Clorox or something. That makes them a little brittle. So. Again, try to get down to the bottom of the floor of the pulp chamber there when you're applying pressure with your elevator. Got a little motion there, and I'm not sure it's going to crack. Something broke there. We'll see. Hopefully it broke along the lines we want it to break, but these are brittle teeth. They're going to shatter like a piece of porcelain rather than a piece of oak. You got just a distal crown. That's all right. Probably will have enough room. Again, with the distal crown off there, this mesial will probably just elevate into that space here. We'll see how it is. We'll give it a try there. Just going to elevate it back to that space we created by removing the distal tooth, and then we can see if we can take this part out here. I think we still have a little root tip in there. That's all right. Let's see. always keep your pieces on your tray because you put it back together like a puzzle sometimes. Let's see, compare that to the radiograph. There's probably a little piece in there, so we'll see if we can find it down there. A little unusual. I never had to fish out teeth out of wax before, but oh, there it is right there. Okay. There we go. That's going a little more distal. There's our distal piece. And that's typical. That happens a lot of times. They'll break off just like that, and you have to fish around there with a small instrument like that. Again, you can use whatever you want. I just use this little Woodson, almost like a peritone, minimally invasive. You can feel around with it. Again, sometimes I'll go in there with my little 15 scaler because you can reach around in there and feel things in there. And also, you can get into when they're down there real tight, you can get into a little periodontal ligament space around there and get a little opening in there, and then you can use your Woodson and get down in there. So, okay, we're 2 for 2 sort of, although it didn't, like real life, it doesn't always go strictly according to game plan, but I think you got the basic principles there, and incisions and all that are the same. So actually you should use that as a word of encouragement. If things don't go exactly perfectly the first time you try it, that's the way it is. So. Okay, nice clean socket there. Again, we'll just suture that up. A word on suturing. Again, these are completely impacted teeth, but even though they're completely impacted, when I cover them up, I like to cut out just a little piece of the tissue there. I don't like to hermetically seal sockets. You always want to leave a little space open there so that it can bleed out and get air, pressure and stuff. There's some studies just recently in OOO, I think about 6 months ago, they did a study with total primary closure and then also secondary closure, and they heal a lot better if you have just a small opening there. Let it bleed out, let the pressure get out of there, let air get in there, you can clean and everything. So even though it's completely covered with tissue when you lay the flap, when you finish it, just cut off a little bit so there's a little bit of opening, maybe a third the size of the socket there, so you can get air and water, and it can relieve the pressure there. Okay, that's our first 2 there. So we'll move